my name is Anthony Zong, and I'm a rising senior at Detroit Country Day School and the youth leader of First Aid OnSite Foundation. First Aid OnSite Foundation is a 501c3 nonprofit organization dedicated to cultivating, inspiring, and motivating future innovative leaders who are interested in healthcare services. I'm excited to co-host tonight's seminar with my friend Harold Wu.
Hello, everyone. My name is Harold Wu. I'm a rising junior at Bloomfield Hills High School and also a member of the mYe's Youth Leadership Committee. Michigan Youth Empowerment Foundation, also known as mYe, is a 501c3 nonprofit foundation dedicated to empowering students ages K through 12 with the tools and knowledge necessary to succeed in the 21st century. mYe's programs are designed to foster students' interest in STEAM, leadership, and entrepreneurship, helping to bridge the gap between academics and the real-world technology applications. We are very honored to be tonight's co-hosts.
Next, we would like to introduce another organization who is co-hosting the event tonight, Dragon Eagle TV. Dragon Eagle TV is an influential media group under GL Media Group. It's headquartered in Detroit, Michigan. The mission is to build social, cultural, business, educational, and political bridges among the community. Thank you, Dragon Eagle TV, for your support of tonight's program.
As part of the benefits for tonight's seminar, everyone who attends this seminar tonight will receive a code that will allow you to watch two phenomenal documentaries. Screenagers and Screenagers Next Chapter will both be provided to you for free. The total value of these two documentaries are around $40, so make sure you take advantage of both of them.
Screenagers is a multi-award-winning documentary addressing many mental and emotional challenges teenagers face in our digital age. In Screenagers Next Chapter, Uncovering Skills for Stress Resilience is a film that examines the science behind teens' emotional challenges and the interplay of social media, and most importantly, what can be done in our schools and homes to help them build crucial skills to navigate stress, anxiety, and depression in our digital age.
We would also like to introduce the Inspiring Role Models Virtual Conference, also known as IRM for short, an online event aiming to motivate youth to fully invest in themselves and explore their passions. It is also co-organized by mYe and First Aid OnSite Foundation of America. It is a great opportunity to get close interactions with inspiring role models across different industries. To sign up, make sure to go to myebeat.com/IRM-event. I will make sure to provide the link in chat, so make sure you sign up there.
Before we officially start tonight's program, I want to remind everyone to use the Q&A box in the Zoom for any questions. And you have the option to leave questions anonymously if you are not comfortable disclosing your name. Now, I would like to introduce our guest speaker, Dr. Klisz-Hulbert. Dr. Klisz-Hulbert is a clinical assistant professor in the Department of Psychiatry and Behavioral Neurosciences at Wayne State University. She completed psychiatry residency and fellowship training in child and adolescent psychiatry at the Detroit Medical Center, where she is currently the fellowship program director. She is active in several national and regional professional organizations and is a distinguished fellow of both the AACAP and the APA. Dr. Klisz-Hulbert is a past president of the Michigan Council for Child and Adolescent Psychiatry and is an active member of the recruitment committee for the American Association of Directors of Psychiatric Residency Training. She is active in supervising and educating CAP fellows, psychiatry residents, medical students, and graduate students, as well as other clinicians and educators. In addition, she provides clinical care to children, adolescents, and adults at a university outpatient clinic, consults with numerous school districts, and provides emergency screenings at a community mental health crisis center. In today's program, Dr. Klisz-Hulbert will cover the following topics: differentiating normal from problematic anxiety, identifying warning signs of depression in adolescents, discussing treatment of depression and anxiety in the youth, and utilizing resources to learn more about adolescent mental health. Please join me to welcome Dr. Klisz-Hulbert.
Thank you very much, Harold and Anthony. Thank you for coordinating this, and thank you to Nicole and Grace for inviting me to be part of it. So I thought we'd talk just a little bit about anxiety and depression in youth before we kind of move on to more questions. So first, thinking about depression and mood disorders in kids. Adolescence is a time where teens can be moody, teens can be rebellious, and a lot of the times we write those things off as normal. They're going through a lot of changes, they're learning to cope with new stressors, relationships, sports, where they want to go to college, all of those big decisions. And that can lead to teens kind of feeling demoralized at some time and irritable as well. And that's a normal part of development. However, not every upheaval that happens during adolescence is just a phase. And we want to be cautious of knowing what are the signs where we can think that something is maybe more than just a phase and we need to be concerned. So some of the warning signs for depression in children and adolescents would include things like unusual sadness, irritability, acting out behaviors, losing interest in things that they used to enjoy doing. So they used to play a sport, they don't want to do that anymore, or don't want to belong to a group or hang out with their friends. Changes in sleep and appetite, decreased energy, feeling worthless, hopeless, guilty, those types of things, drops in grades, relying on drugs or alcohol to help them feel better, or kind of somatic complaints, aches and pains without any real physical cause identified. If you start to see multiple of those symptoms in your child, then that would be a time that you might want to be concerned, particularly if those things go on for a couple of weeks at a time, almost every day, most of the day, then that could be symptoms of depression. There's some important differences when we think about depression in our teenagers versus depression in adults. So in adults, you may see more of the low mood, just kind of that blah feeling and lack of interest. In teenagers, you can see it manifest more with irritability versus the low mood. They may not complain about feeling depressed, but they may be very irritable and grouchy and kind of make you feel like you're walking on eggshells as a parent. With adults, we're more likely to see appetite decrease and weight loss, whereas in adolescents, you can see those symptoms, but you could also see increase in appetite and weight gain that's inappropriate. In adults, we typically think of them not sleeping. In teens, we may see them sleeping more than they used to. We can still see that lethargy or just kind of not feeling motivated, not wanting to do anything. In adults, we often talk about kind of loss of libido. We tend not to see that as much in adolescents. But probably the biggest difference between adult depression and adolescent depression really comes down to reactivity. So with adults, you know, their friends can force them to go out to dinner, but they probably won't have a good time. They don't enjoy themselves. In teenagers, they can get kind of a brief reprieve from the depressive symptoms by going out with friends, by doing things that they enjoy. And so going to their favorite restaurant, they might feel better while they're there. And sometimes parents will say, well, look, he's not depressed. He had a great time at dinner last night, or we went to Disney World and she did great. But that's not necessarily the case in teenagers because they do tend to be more responsive to their environment and tend to then increase and want to look for those things. And we become particularly concerned when that is accompanied by risk-taking behaviors. So if kids are going out to a party and experimenting with drugs or alcohol, and that starts to make them feel better, then we can start to see those patterns increase. And that actually is a symptom of depression, even though they are, you know, reacting to their environment and feeling better. So something to keep in mind. Some facts about adolescent depression, it's not rare. So data from 2017 tells us that about 13.3% of teenagers, so between the ages of 12 to 17, had what we would consider a major depressive episode. And almost 2/3 of those kids did not receive any treatment. So it's much less likely for them to receive treatment. If you look at CDC data, it shows us that by the time kids are 18, about 37% of them will have experienced persistent sadness or hopelessness and almost 20% of them will have seriously contemplated suicide at some point in their adolescence. A large number of adults that are diagnosed with depression had their first episode of depression when they were a teenager. And typically that first kind of peak in depression occurs between the ages of 13 and 14. And again, we're concerned because we worry about the academic and social impairments associated with adolescent depression. We worry about self-injury, which we'll talk about on the next slide, self-medication, using drugs and alcohol, increasing the risk for depression in adulthood, and of course, the worst case scenario, which would be suicide. And suicide is on the rise among adolescents. After a many year period of it slowly kind of declining, it's starting to peak back up again, and that has many of us concerned. Right now, it's the third highest cause of death in adolescents. When we think about depression, oftentimes we think about self-harm. So as many as a quarter of teens may engage in self-injurious behavior. Self-harm is typically defined as any repetitive, socially unacceptable behavior that results in mild to moderate physical injury without the intent to die or to kill oneself. As many as 1 out of 4 teens, again, will self-harm. It does tend to be more common among girls than boys. And the most common form of self-harm is typically cutting, but kids may also engage in things like burning, scratching, pulling out their hair, hitting body parts, or picking at scabs, interfering with wound healing in an intentional way, not in a kind of mindless picking way. Self-harm does tend to be addictive. There is some dopamine release that is, that is affiliated with it. And you can see it start to increase and escalate if that pattern is not interrupted. So studies have shown us that if you can stop the behavior before it's happened about 10 times, before 10 self-harming acts, the prognosis is much better before it becomes more of an addictive type behavior. Typically, there's 2 forms of self-injury that we think about. Oftentimes, teens are harming because they feel nothing. They're so depressed or so anxious that they feel numb, and so they inflict pain on themselves in order to feel something. And the other case may be where their feelings are just so overwhelming and so difficult to manage that they cut because it's a type of feeling that they can control. And so they cut to make those feelings go away. Some red flags for parents who may be concerned about your kids would be if you hear your kids talking about self-injury, you see suspicious looking scars or wounds that don't seem to heal or get worse, cuts that are found in the same place, kids spending more and more time in their room, isolating, finding tools that they may use to self-harm, such as razor blades, shards of glass, that kind of thing. Kids may wear long sleeves, even though it's warm weather, to try and hide the evidence of self-harm, avoid social activities, refuse to go into the locker room or change clothes at school, that type of thing, to avoid anybody seeing their injuries. So those would be some warning signs to look out for. As far as going off to college, this does tend to be a really risky time for many teenagers. College is often considered an opportunity to kind of leave home, to start over in a new community. And while a lot of young adults really thrive in those circumstances, others may have a really difficult time adjusting. While teens naturally tend to become more independent during college, it's important to kind of stay in contact with them, continue offering parental support, be on the lookout for signs of depression or adult onset bipolar disorder, which typically starts around age 19 or 20. Bipolar disorder can have similar symptoms as depression with an additional component of manic behavior or really uncontrollable behavior. You tend to know your kid better than the new friends that they're making. So you may be the first person to notice that something's not right. And so being aware of that and being mindful of it. For kids who are already diagnosed with a psychiatric disorder, It's important for them to keep taking their medication once at college, to coordinate with campus mental health or a local provider to continue treatment while they're away. While if college is a new beginning, psychiatric disorders typically don't just disappear. And the beginning of college is not a good time to experiment with ending treatment or adjusting meds. Best to do those things before college begins under a doctor's supervision. When we think about treatment for adolescent depression, research really shows us that there's a window between 2 to 4 years between the time the first symptoms of depression are noticed and really a full-blown major depressive disorder develops. And treatment during that period of time tends to be particularly effective. As many as 80% of teenagers that are suffering from depression can be successfully treated if they seek help from a doctor and or therapist. Mild depression is sometimes treated with just psychotherapy, but most experts agree, particularly for moderate to severe depression, that the combination of psychotherapy plus medication usually has the best results. When we think about treatment with psychotherapy, this includes a number of different modalities, and that somewhat depends on the particular child that we're treating. So one of those types of treatment is called interpersonal therapy. When we think of interpersonal therapy, really one of the most important factors in kind of maintaining mood and healthy functioning is interpersonal relationships with peers, family, things like that. And IPT typically focuses on kind of revising those interpersonal relationships and making sure that you're getting positive reinforcement from those relationships. Behavioral activation consists of really encouraging kids with depression to participate in activities that they've lost interest in, with the goal of trying to kind of jumpstart recovery, trying to get kids out there and kind of out of the slump that they've been in. And then one of the most common interventions is cognitive behavioral therapy. So CBT involves the connection between your thoughts, your feelings, and your behavior. Kids with depression typically have very negative thoughts that kind of keep them feeling depressed. And CBT teaches kids how to be aware of their thoughts and how they affect their feelings and behavior, and how changing one of those 3 components can then lead to change with the other 2. We also, like I said, especially when depression is moderate to severe, may use medication to treat depression. Many medications have been proven effective in combating depression. Typically, a course of therapy begins with selective serotonin reuptake inhibitors, or SSRIs. These are medications that increase the supply of certain neurotransmitters, which are chemicals used for communication inside the brain. And a shortage of serotonin has been associated with depression. Other medications that we use include serotonin and norepinephrine reuptake inhibitors. So SSRIs would be medications like Prozac or Zoloft, Celexa, Lexapro. Serotonin and norepinephrine reuptake inhibitors would be medications like Effexor or Cymbalta, if you've heard of those. And then there are a couple medications that work with norepinephrine and dopamine, which includes medications like Wellbutrin. The FDA has decided, really based on all of the research, that all antidepressants do have a slight risk of increasing suicidal thoughts, and they carry this black box warning label because of that. It's important for parents and for kids to know that that phenomena is actually very, very rare. And it's really only been tied to suicidal thoughts, not actual suicide attempts. And there's a number of different theories about why that may be. It may be that kids are feeling better, and so they're talking more about the thoughts that they're having, those types of things. But what we do know based on the evidence is that the benefit of these medications and the potential to improve and prevent suicide attempts is actually much greater than any of the risks. And so we monitor kids carefully, but it doesn't stop us from utilizing these medications. Okay. That's all I had for depression. And I know there will be some questions, and I'll kind of come back to those at the end. I wanted to shift now to talk about anxiety and kind of when to worry about your child's worries. Anxiety is actually one of the most common diagnoses or group of diagnoses that we tend to see in kids and adolescents. It's important to realize that anxiety is normal. Everybody has anxiety. If I didn't have any anxiety, I would have never been motivated to study for medical school and never would have gotten to where I am today. So we worry about anxiety when it becomes pathological, when the anxiety kind of loses touch with reality. It becomes a problem when our bodies start to kind of warn us about dangers that aren't real, okay? While being anxious is unpleasant, the discomfort that anxiety brings can be considered normal and again, even beneficial, like preparing for a test or things like that. Anxiety can be a motivating and productive force, but when it starts to interfere with how we want to live our lives, that's when it becomes problematic. So when we think about when anxiety becomes problematic, it's really about when it starts to interfere with functioning. So when feeling anxious in response to a stressful situation, if it starts to impact the ability for a teen to handle everyday situations or prompts them to avoid things that most kids their age are doing, then it becomes problematic. If they're not able to recover, even when the stressor is no longer there, that's another sign that it would be problematic. So we think about severe anxiety. Some of the characteristics include anxiety that really is unrealistic, okay? So a teenage girl who has sex might worry that she's pregnant. That's a realistic worry. A teenager who's never had sex worrying that she might be pregnant, we would consider that to be an unrealistic fear. And that would be something that we would be concerned about. We also are concerned when anxiety really is out of proportion to whatever the trigger is. So, you know, a sophomore who's taking the SAT, it's probably appropriate to be anxious. But you may have a kid who's staying up all night worrying about taking the SAT, but he's only in 3rd grade. That's more problematic and something to be more concerned about. Okay. Severe anxiety can also be seen as being kind of overly self-conscious. So teenagers often feel nervous about interactions with other kids that they may be interested in romantically, things like that. It's appropriate to be nervous in those situations. But kids with maybe social anxiety might avoid talking in front of anyone, even to order at a restaurant or something like that, because they're afraid of humiliating themselves. Severe anxiety typically is unwanted and uncontrollable. A kid who cries when he's dropped off for kindergarten because he's separated from his mom, but recovers pretty quickly would be normal. A kid who's not able to rein that in and continues to cry because they think about all the ways that his mom is going to die when they're not together, that's more problematic, and that's when we become concerned. We also get concerned when the severe anxiety doesn't go away. So even after the stressor has resolved, they continue to be worried about whatever it is, continue to be preoccupied with it. That's a cause for concern. And then probably one of the biggest things that I tend to see in the kids that I treat is avoidance type behaviors. So kids who are avoiding going to school because of things that make them anxious at school, or, you know, avoid going outside because they're afraid of dogs, even when there's no dogs in their fenced yard, but they won't go outside. So those kind of unrealistic avoidance type behaviors are another reason that you would be concerned. So some facts about anxiety disorders: almost 32% of American kids meet criteria for an anxiety disorder by the time they're 18. Anxiety disorders tend to be among the greatest predictors of mood disorders later on in life, as well as alcohol abuse. So one of the most important things about childhood anxiety is how it can lead to other types of disorders later on. And that can be mitigated with appropriate treatment during childhood. More than 40 million adults in the US, about 18%, have reported disabling anxiety that negatively impacts their life. So oftentimes the anxiety does not go away as kids grow up and get older, but it may become more severe and more impairing. There are several different types of anxiety disorders that we typically treat. So one is generalized anxiety disorder, or GAD. So this is a condition that's characterized by kind of pervasive, unwanted worries about a variety of everyday things. Pretty much they worry too much about everything. In kids, it's often focused on kind of performance things like school or sports performance, and may drive them to study a ton, practice an inordinate amount of time, things like that. Unlike in adults that have generalized anxiety, kids with generalized anxiety typically don't realize that their fears are kind of out of proportion or unrealistic. It's up to the adults around them to recognize that for them. Some symptoms of generalized anxiety include kind of the kid who's a worrywart. They worry incessantly about everything, particularly about performance, ability to meet expectations, things like that. They may ask frequent questions or may ask the same question over and over and over again because they're trying to seek reassurance. They may be kind of rigid, irritable, restless, things like that. Oftentimes I'll describe these kids as kind of sticky kids. Once they get kind of focused on a fear or a worry, you have a hard time shifting them off, and difficulty kind of getting them to think about something else. They may have physical symptoms like headaches, stomach aches, fatigue, things like that. And oftentimes the fears are exaggerated, but they're based on kind of tangible real life issues, like weather, school performance, that type of thing. Another common anxiety disorder that we see in kids and teenagers is separation anxiety disorder. So this is a disorder that causes a child or adolescent to have extreme distress when they're separated from their parents or caregivers. Typically, this is a normal behavior when we see it in little kids. So in like preschoolers that are going off to school for the first time, toddlers, we often see them have what we consider normal separation anxiety. But when we start to see it in school age kids or adolescents, then we become more concerned because it's not developmentally appropriate any longer. And typically it interferes with more age appropriate behaviors that these kids should be engaging in, like going to school. Some of the symptoms of separation anxiety include extreme dependence on parents, persistent perception that either they are in danger or their parents are in danger when they're separated from each other. These may be the kids that kind of shadow parents around the house. You can't go to the bathroom by yourself as a parent. They may be whiny, clingy, demanding when they're not getting attention. They may have difficulty sleeping without a parent, that type of thing. They may have physical symptoms when they anticipate a separation. So stomach aches, headaches, dizziness, things like that. And that can lead these kids to have numerous absences from school because they avoid going to school because of that separation. They may also avoid things like play dates, birthday parties, really going anywhere without the parent. Younger kids that have this tend to be the most anxious at the time of the separation. Whereas when kids get older and have kind of a better concept of time, you start to see more of the anxiety become anticipatory, where it's more leading up to the separation. That's when the anxiety starts to peak. Another common anxiety disorder that we see, particularly in teens, is social anxiety disorder. So this is characterized by kind of excessive self-consciousness that really goes beyond common shyness or nerves. Kids with social anxiety tend to get so worried about being judged negatively by others that they are terrified to do anything or say anything that could cause humiliation. This fear typically feels uncontrollable. And even though older kids realize that it may not be a realistic concern, it doesn't calm the anxiety. Again, typically this is affecting adolescents. And oftentimes there's kind of two big features to it. One is performance anxiety. So this would be things like speaking in class, ordering in a restaurant, shopping in a store, anytime where a teen would be kind of put on the spot and people are looking to that person to say something. And then the other time is more interactional. So this focuses on kind of social situations, even when the kid is not in the spotlight. But things like just going to school, eating in public, using public restrooms, things like that. They typically have a lot of anxiety about being in a situation where other people are going to see them and may judge them. And you may have both types together. Because social anxiety can lead to a lot of avoidance, it can also then lead to isolation and depression. Teenagers need social relationships and peer relationships to develop appropriately. And when anxiety limits their ability to do that, you get more depressive symptoms and isolation. Some of the symptoms of social anxiety disorder, so an inordinate fear of criticism. Kids with the disorder typically express their anxiety by saying things like, what if I do the wrong thing? What if I say something stupid? People are going to laugh at me. People are going to make fun of me, that kind of thing. Young kids might throw tantrums or cry when they're put in front of a situation that terrifies them. And then you may see physical symptoms that we might associate with an anxiety attack, like kind of shaking, sweating, shortness of breath, those types of things, or just refusing to speak in front of others in general. A less common anxiety disorder that's really more specific to kids is called selective mutism. This is kids who are perfectly capable of speaking and they talk very fluently and in fact maybe overly talkative at home, but they refuse to speak in social situations, refuse to speak at school, refuse to speak in the presence of others or those types of things. Typically, this starts with younger kids, ages 3 or 4, but I do have several kids in my practice that are teenagers and continue to struggle with selective mutism. We don't want to confuse it with kind of just the shyness of the first few weeks at a new school or reluctance to adapt to a new language or things like that. This is something that persists beyond that timeline. It can cause a lot of distress. The kid with selective mutism typically can't communicate, even say if they were in pain or had to use the bathroom, things like that. It also prevents them from participating in other types of age-appropriate activities, sports, school, that type of thing. So some of the symptoms for selective mutism would be kind of a kid who talks and is very freely verbal and gregarious at home. But then when you go to school, they completely shut down and don't talk. They may seem kind of like paralyzed with fear. They may use gestures or facial expressions to communicate, kind of nodding or things like that. But even some kids with selective mutism won't even communicate non-verbally. They just completely shut down. Another type of anxiety would be specific phobias. So these are kind of excessive, irrational fears of either an object or a situation that's not normally considered dangerous. Kids with specific phobias aren't generally anxious, but they're only anxious in the presence of whatever that trigger is, whenever they're confronted with the thing that causes them terror. That confrontation can be direct or indirect, so the thing could actually be there, or it could be somebody just talking about it. So common things that kids have phobias about would be storm, water, heights, insects, dogs, cats, blood, needles, things like that. And again, like in some of the other anxiety disorders in kids, adults and adolescents may realize that it's not an appropriate fear, but kids have difficulty recognizing that it's not a realistic fear or that the fear is unwarranted. Some of the symptoms, unreasonable fears, avoidance, possibly tantrums when they have to face whatever it is that they're afraid of, and then physical symptoms, things like trembling, dizziness, sweating, that type of thing may be common. And then the last anxiety disorder that I just wanted to touch on was obsessive-compulsive disorder. So this is a little bit different. It's characterized by kind of unwanted thoughts, images, impulses, which we call obsessions, that a kid typically tends to try to fend off or neutralize by performing compulsions, which are ritualized or repeated behaviors. OCD can manifest as young as age 5, but often in younger kids, they don't have the self-awareness to really recognize that the thoughts and the fears are exaggerated or unrealistic, and they might not become fully aware of why they have to perform these different rituals. Oftentimes, younger kids will talk about they have to do a certain ritual because it just gives them this just right feeling. They have to do things until they're just right. So symptoms of OCD would include kind of ritualized compulsive behaviors like repeated hand washing, locking and relocking doors, touching things in a certain order. Now, this is a hard one in this day and age. Everybody is washing their hands a lot more than normal, but we're talking in excess of what everybody else is doing, washing their hands to the point that it's taking 2 hours of their day that they're spending washing hands, or washing hands to the point of hands becoming red and chapped and cracked. These kids may have extreme fears of contamination, of family members becoming hurt or harmed, or doing harm themselves. You might also see kind of magical thinking. So kids feel like if they do a certain thing, it's gonna prevent something else from happening. So the old saying, like, step on a crack, break your mother's back. A kid with OCD may think like literally if they step on a crack, something bad's going to happen to their parent. Or if they do a certain thing by touching everything in a room a certain way, it's going to protect their parent from coming to harm, or those kinds of things. So it's kind of unrealistic behaviors that aren't necessarily related to the fear that they're trying to prevent. These kids may have a lot of reassurance seeking. So again, that repeated questioning about the future or things like that. And they may be intolerant for certain words, certain sounds, kind of hypersensitive about particular things as well. What to do when you have a kid who is anxious? So the best way to overcome anxiety is not to remove the stressors that trigger it. I'm a parent of 2 kids myself. None of us like to see our kids suffer, but we have to be mindful of just removing all of the stressors doesn't really teach our kids how to manage stress. It just lets them avoid it. So kids tend to do best when they learn how to tolerate that anxiety and function in spite of it. As a byproduct, then that helps the anxiety gradually fall away over time. As kids master it and see that nothing horrible does happen, the anxiety becomes less and less. So we want to kind of let kids learn how to cope with anxiety by setting good examples. If they hear us as parents complaining about stress or anxiety, they may internalize that. So we want to model for our kids effectively managing our own anxiety. And that may mean getting treatment for ourselves if we suffer from our own anxiety. You want to avoid reinforcing a child's fear by appearing anxious yourself. So even if it's something that you're worrying about how your child's going to respond in a certain situation, you want to try to maintain a very calm voice, calm body language, all of those types of things. The more that you appear anxious, the more it legitimizes their fear. I always use the example of, every one of us as parents at some point, our child came into our room and was afraid of a monster in their room. And, most of us would walk our kid back into their room, assure them there's no monster, try to get them to go back to bed. If you repeatedly go, oh, there's a monster in your room, here, come into bed with mom, what you've just done is kind of legitimized their fear. You've told them that, oh, there is a monster in your room and there's something for you to be afraid of. So we want to avoid doing that. We want to, appear calm ourselves. We want to reassure the kids. And we don't want to do things like ask leading questions. You don't want to go to a kid who's anxious and be like, are you worried about the big test? Try to avoid that type of stuff. Ask more open-ended questions. How are you feeling about the test coming up? Versus kind of putting thoughts into their head or implying to them that they should feel anxious about something. Again, you don't want to avoid scary things because it'll make the kids feel better in the short term, but it doesn't teach them any skills And it actually tends to reinforce their anxiety and prevent them from learning those coping mechanisms. Some kids might benefit from having conversations about kind of what's the worst case scenario. So what would be the worst thing? My son has anxiety that I'm not going to pick him up from school someday. I've never forgotten to pick him up from school, but for some reason, if I'm late for a couple of minutes, he's on the phone calling me. What's the worst thing that happened if mom didn't pick you up from school? We live a few blocks from the school. You could walk home, right? So what would you do if that happened? How would you handle it? What's the plan? And that can help reduce the uncertainty. If the anxiety is severe and it's interfering with your kid's ability to function, then finding a mental health professional who can help is really important. So treatment for anxiety disorders in kids tends to be primarily psychotherapy, although again, sometimes we do combine with medication, really depending on the type of anxiety, the age of the kid, and the severity level. But treatments for anxiety actually tend to be very successful in helping kids overcome anxiety and then reducing future negative outcomes as well. So that's all that I had as far as information. I did want to share some additional resources with you guys. I know teenagers like to do a lot of research on their own, and I am all for that. I think that's great, but I like to give my adolescents some good resources, because just asking Dr. Google is not a great way to go. You can find lots of information that's not necessarily the most appropriate. So here are some good resources for learning more about a variety of different mental health conditions. AACAP is the American Academy of Child and Adolescent Psychiatry. APA is the American Psychiatric Association. And then I actually and both of those have kind of for families and parents tabs that give you lots of information and lots of resources. Another one that I really like, where I pulled a lot of these slides from, actually is Child Mind Institute. And they have a number of different articles and posts and things like that about a number of different mental health symptoms and things like that. The National Association for Suicide Prevention online, American Foundation for Suicide Prevention, and then suicide prevention, particularly for adolescents, is on there as well. You can also look for on ACAP and APA will have lists of providers in your area. You can look at your health insurance provider and who is covered under your health insurance. And then most areas have a community mental health system that has robust services for children and adolescents with mental health conditions as well. So thank you very much for joining us today to learn more about these topics. If you want to find out more, again, I encourage you to go to these different resources. Thank you.
Before we move on to the Q&A section, we would like to share the registration information for the screening. You may take a screenshot of the Google slide provided if you would like to. And just a reminder to everyone, I saw that some questions were posted in the normal chat. If you have any questions that you want Dr. Klisz-Hulbert to answer, just a reminder to make sure you put it in the Q&A chat instead of the normal chat. We'll get those all answered for you guys.
To start the Q&A section, we will go over the questions that were pre-collected during the registration process before we answer the questions in the Q&A box. And there's only a few of these, so it won't take too long. But the first question is there any advice for kids with ADHD in college to manage their stress?
That's a great question. So college can be a stressful time for any kiddo, and particularly for kids that may have ADHD or depression, anxiety, things like that. I think the first kind of goes back to what I said on one of the slides, which is don't stop taking your medication, don't stop going to therapy. You want to continue using the resources that have worked for you thus far. I think some planning ahead is important. And some of this depends on the youth and kind of their strengths and areas of need and things like that. But thinking about, setting up resources on campus, whether that's the campus mental health clinic, or a local provider. So making those connections ahead of time and figuring out where you're going to go, scheduling an appointment versus waiting until you get to school and first semester goes by and now you're failing and you've got to scramble to try to get in somewhere. So thinking ahead of time and planning things out. I think, building a support network is really important. So thinking about different strategies that you can use to try to help, particularly with ADHD. There are a lot of supports out there. There's a great website called chadd.org. They have support groups for adolescents and things like that. Lots of tools, apps that can be really helpful to help with organizing and things like that. And oftentimes, ADHD is a very, very common disorder. So there's going to be other kids that are in the same boat as you. There may be groups within the college where those kids can help get additional support. And then I know many universities have, I forget what it's called. It's not necessarily, special education services, but they have a student support center where they can help you with things like time management, with things like, planning your courses appropriately, those kinds of things, keeping in mind, again, your strengths and areas of need, particularly as it relates to ADHD. So taking advantage of all of those resources and, again, planning it out and doing those things early versus thinking, I'm just going to go to college and not take my meds and I'm going to do fine, and then trying to play catch up afterwards. So, plan those things out, do it. Maybe you find you don't need some of those resources and you can trim them down. That's great, but it's better to kind of over prepare versus under prepare.
All right, thank you so much. Our next question is, do you have any data on student mental health issues caused by school closure?
Yeah, so there's actually a lot that's been out there looking at kind of the impact of the pandemic. I don't know that I have really good numbers because they do tend to be changing. In every study that I look at, the numbers seem to be getting higher, which is a concern. And also, I think a lot of the data is still being collected and we don't know yet. But there's a number of factors that really have gone into what we do know is a significant worsening of mental health, particularly in our adolescents and young adults. When we think about the impact of the pandemic, it's really our adolescents and our young adults who have been hit the hardest. Younger kids tend to be have a lot of resilience, have a lot more support. Things may not have changed as much for them. And then adults have a lot more control over things and have more of a sense of being in control. Although even for many of us adults, it's been stressful. But for our teenagers, you have multiple things going on. So you've got, they're already in this time of transition and things like that. And now you have the lack of what is really one of the defining things about adolescence, which is social relationships. And all of a sudden, you can't do that anymore. You can't hang out with your friends. You can't go to school. You can't, even if you are in school, you can't sit by your friends, all of those types of things. So you've got that. You have many kids who now are stuck at home, and maybe their home situation is not the greatest, and that continues to exacerbate their mental health. School may have been a source of kind of comfort and resilience for them, and now that resource has been taken away. There's concern about increasing rates of abuse and neglect because more kids are home, more parents are stressed because of job loss, things like that. And kids aren't going to school, and teachers typically are the number one reporters to Child Protective Services when there's concerns about abuse or neglect. So we have those things going on. And then the other big thing, and I see this in the school consultation work that I do, really has been the limited access to care. So many providers were able to switch successfully to doing telehealth services, but some weren't. I've seen many kids who had a therapist and that therapist just stopped seeing them because of the pandemic. Or they're only seeing them virtually, and that's not appropriate for all kids. It's many kids, we're doing this virtually, but in person is oftentimes the best thing, particularly when it's a sensitive subject. And so you've got those limits going on. Again, there's a lot of things going on. We do see in many settings, we've seen suicide rates go up. Kids in emergency rooms more frequently presenting with complaints and concerns, and kind of just increase in loneliness, isolation, leading to worsening of anxiety and depression, for sure.
All right, thank you for that answer. We're gonna move on to our third question, which is how to build trust when the teen does not want to open and share any of the issues.
Yeah, so there's a couple of questions too in the Q&A that I think are kind of related to this, different ways of asking the same thing. I think, there's a number of things that you can do as a parent, but you have to keep in mind that you know your kid best. So some of the suggestions that I make, and again, you have to kind of pick what you think is going to work for you and your family. But oftentimes sitting down with your kid at the dinner table, face to face, and interrogating them about what's going on is going to be your least successful alternative. Kids, do you guys like to be interrogated? No. Harold and Anthony are shaking their heads. No, nobody likes that. So, starting the conversation in a positive place. Sometimes that may be by revealing something that you've struggled with so that your child knows that this is not something you're going to judge them about. Sometimes that may be having the conversation in somewhat of a less threatening place. I found out with my own daughter, who's 15, when we're driving to and from dance class and she's sitting in the car with me next to me, but we're not making direct eye contact, she'll tell me a lot more stuff because it's not that confrontational. And so we get a lot more, and we have very rich discussions in that kind of informal setting. So those types of things can be helpful, really trying to kind of build the rapport and the relationship with your teenager. Asking more open-ended questions, that type of thing. And then I think if you are concerned, you can bring your child to a trusted physician, whether that's your pediatrician or primary care doctor. If they're refusing to seek help from a therapist, maybe involving the school counselor or the school social worker may be a helpful way to go. So trying to find someone who the child does have a positive relationship with and is willing to engage with, and then kind of building off of that can be helpful as well.
Thank you so much. All right. Our fourth question for tonight is to follow up with what you said in the last question. How would you suggest teenagers control their usage of social media?
Social media. So I think this is a balancing act, right? Because social media is the future. This is the main way that our kids keep in contact with each other. And so just kind of completely wiping it off the table and eliminating it can oftentimes cause more harm than good, because then our kids lose those pro-social connections that they've made. So I really like to think about it as, working with our kids to teach them about appropriate social media use. The American Academy of Pediatricians, actually, that's another resource I should have listed. They have some great pages on their website that talk about kind of social media use, really from very young kids all the way up through adolescents. And they give some kind of guide points about different things. But particularly for adolescents, again, adolescence is a broad range, and not every 13-year-old is the same. So you have to really look at where your kid is at and what you think they are ready for. There are numerous apps out there that parents can use to kind of restrict certain social media apps. So things that may be, more controversial or more damaging. You can use the apps to restrict their use of those things. And that's particularly helpful for kind of our younger adolescents that are just getting phones and that kind of stuff, 13, 14, that kind of thing. And then kind of gradually giving some of that power back to the kids as they get older. And for kids themselves that want to curb their social media use that maybe are starting to find that it's becoming a bit of a problem. There are some apps out there that you can download that will actually keep track of your screen time and give you pop-ups and warnings saying, hey, you've been scrolling TikTok for an hour now. Maybe it's time to take a break. So that type of stuff. A great resource for parents is commonsensemedia.org. They have lots of resources. I find it really helpful as a parent. My kids will come home and ask me if they can get a certain app, and I can go on there and look up and find out what the app is all about, hear from other parents whether they think it's a good thing or not a good thing, hear from kids what they think about it, and then make an informed decision. So I would encourage parents to check that out as well.
All right, thank you. So now we're moving on to our last question, Q&A question that was during the registration process. And this question is, how to persuade a teenager to actively engage in treatment and eventually taking the initiative?
Yeah. So I think, again, that kind of goes back to a couple questions ago. You cannot make a teenager do anything. And that's what I tell the kids that come into my office to see me. Listen, I cannot force you to get better. I cannot force you to get out of bed. I cannot force you to take this medicine. That has to be a choice that you make. But, kind of working through the pros and the cons, helping a kid take maybe a critical look at what's going on in their life and what they're happy with and what they're not happy with. And are they willing to work on some of the things that they're not happy with? In mental health, we call this motivational interviewing, where we really are trying to meet kids where they're at and try to I don't even want to use the word nudge, but you try to meet them where they're at and then figure out what's important to them. Because what's important to them may not always be what's important to you. However, I would say most of the time when I meet with kids and families and they seem to have kind of discordant goals, what's important to the kid is not necessarily the same thing as what's important to the parent, but the two goals align. And so then we can work on those things together, but you have to work on something that the kid is interested in working on. Otherwise, they have no motivation. They feel like they're just being told what to do. And again, you guys don't like being told what to do you? No, I don't think so.
All right, thank you. So now we will move on to answering some of the questions that were asked in our Q&A chat. So go ahead. I know we have around like 11 questions. Some of them may have already been answered, but feel free to reevaluate on whichever you seek.
Okay.
Yeah.
So let me go here. Somebody asked about thoughts before age 12, but I'm not sure what that was referring to. So maybe they can ask a follow-up question or send me a direct chat. Somebody asked, what are things that look like depression but aren't? There's a lot of different things that can look like depression, and depression often is comorbid or occurs with a lot of other disorders. So we oftentimes see depression and anxiety occur together. We can see depression occur with ADHD. We can see depression occur with trauma-related disorders, things like that. So there's a lot of different things that can look like depression. Also, sometimes there are medical conditions that can present looking like depression. So the most common one that we always think about is thyroid disorders, which can cause low energy. It can cause problems with sleep, appetite, weight gain, things like that. So oftentimes doing kind of some baseline labs, including thyroid screening, is a part of my workup for depression in teenagers. Also looking at kind of vitamin D levels, whether a kid is anemic or not. All of those things typically are included in baseline labs that I'll do at the first visit, because those are things that can kind of mimic depression, but that are easily treatable medically. Somebody asked about kind of depersonalization, derealization. So it's not necessarily a disorder, but that is a symptom that we can see in numerous different types of disorders. So depersonalization is where you feel like it's not really you that these things are happening to, or you're kind of like floating above and watching these things happen to a third party, or derealization that what's happening isn't really real. The most common disorder that we see that happen with is in trauma-related disorders. So when kids have experienced kind of extreme life-threatening situations, witnessed violence, abuse, things like that, it can often lead to those types of symptoms. But sometimes we see them happen with other disorders as well, sometimes with really intense anxiety and that type of thing. It really depends on what else is going on in the clinical picture and trying to kind of just fit that piece in. It's generally a piece of a larger disorder. So that's probably all I can really say about it without knowing more about what's going on. Let me see. So someone again wrote about, that their teenager says she's not depressed and refuses to continue seeing the therapist. I think, talking a little bit more again, like I said, about what's going on, things that are going on that they may not be happy with, and trying to look at it that way. Therapy is like any other relationship. It's all about the goodness of fit. You can have a really great therapist who just may not be a really great therapist for that particular child. And so sometimes it takes a couple of tries to find the right fit. And that may be part of the problem as well. So thinking about those types of things in addition to what we talked about earlier. Somebody else asked about magnesium supplementation. I don't know too much about magnesium. I haven't seen any significant data suggesting that it can be very helpful. So not typically something that I would recommend, and definitely not going to be as helpful as our kind of gold standard treatments of therapy and potentially psychiatric medications. Somebody asked if kids can outgrow depression or anxiety. That's a little bit of a difficult question to answer. Certainly you can see the depression or anxiety kind of resolve. Typically that happens sooner with treatment, but I worry about just thinking that the kid is going to grow out of it, because that's oftentimes not the case. If somebody has anxiety as a 12-year-old and it's not addressed, it's not going to just magically disappear. In most cases, it may develop into something else, and that can be more concerning when we think about substance use disorders and that type of thing. But typically it's not something that they just it's not a phase or something that they would just grow out of. If anything, it may transition into something more concerning. Somebody asked about psychiatric disorders. Are they contagious, influential? So for the most part, no. When we think about psychiatric disorders, we really think about them as having biological, psychological, and social influences that kind of all culminate together to contribute. So certainly the most common case is that a kid has a biological vulnerability, whether that's a family history or something else going on biologically that causes them to be predisposed. And then there may be certain life events that happen that can contribute. Certainly things like having, a really horrible roommate in college could influence them, but oftentimes there's more to it than just that. I would expect a kid without any other risk factors or any other potential for depression to have a horrible roommate, and they might be really irritable that year, but when they're not around the roommate or other things aren't going on, they'd be okay. So I don't like to think that it's not really necessarily contagious. It doesn't spread like that. Although those social and psychological factors can impact mood disorders and anxiety disorders as well. Somebody asked, as a school counselor, there are some screenings that you can do, like the PHQ-9, which is meant for kind of primary care settings. And I think, Kristen, maybe that's something that we should talk about offline, if that's something that you're interested in doing as a school counselor with the kids that you're working with, some screenings that you can use and that type of thing. Let's see, somebody asked if I can talk a little bit more about bipolar depression. So bipolar depression in and of itself isn't typically very different from unipolar depression or major depression. What makes it bipolar depression is that sometimes they are depressed, and at other points in time, they're the opposite of depressed, overly energetic, not sleeping for days at a time because they have so much energy, and they're going to engage in tons of increased goal-directed activity, like they're going to start their own business and they spend a ton of time doing research, and they buy a boat. They may spend impulsively, they may talk really fast, they may lose touch with reality. That's what we would call a manic episode. If someone has ever had a manic episode, then we would consider them to have bipolar disorder. And when they're depressed, then it's bipolar depression. So the depressed phase doesn't necessarily differ from the unipolar depression, but it's important because we treat it very differently because of the risk of having that manic type of presentation as well. Hopefully that was clear. Let's see, somebody wrote that their kid spends too much time playing video games that may have a negative impact on their mental health. I think as far as my suggestions, some of that really depends on the age of the kid. I think for younger kiddos, definitely pre-adolescents, parents should be the ones in control of how much game time kids have. And video games are a privilege, not a right. Sorry, kids. So I think there has to be some degree of control over how, when, and what kids are playing. And then gradually, as kids get older, like we talked about with social media and that type of thing, some of the control gets given back to the kiddo. It's much harder when you're dealing with an 18-year-old who's spending, 20 hours a day playing Call of Duty. You have a lot less control as a parent over what they're doing, but you can then use some of those strategies that we talked about earlier, like thinking about, are they happy with how things are right now? Do they think their video game playing might have some impact in why they're not doing well in school? That type of thing. Okay. Let's see, somebody asked, is it possible to have experienced trauma but not realize it? That's kind of a hard question to answer. I think, typically someone knows if there has been a trauma. Now, certainly kids may have been traumatized when they were very, very young and may not have clear memories of the trauma. So certainly you can see that. Other times, kids may have been traumatized and may have blocked out the memory and kind of avoid talking about it. And that's often a symptom of post-traumatic stress disorder. But it's not quite the same as not realizing that they've been traumatized. I think if you have concerns about symptoms of a trauma-related disorder, to have your child be evaluated by a professional would be my recommendation. Let's see, the next one is about depression, where you mentioned about 12 to 18 years old. Yes, we definitely do have kids under the age of 12 who have thoughts of self-harm. It's typically much less common prior to adolescence, but in some ways it definitely is much more concerning when that happens. And definitely, if we had that in a younger child, it would be cause for evaluation, for sure. Let's see. So a lot of these are kind of about trying to talk to your kids and figure things out and that type of thing. Somebody asked specifically about panic attacks while driving. I think, I try to avoid giving specific recommendations for kids that I haven't personally evaluated, because that can get into kind of dangerous territory. But I would encourage you to reach out to a professional to have an evaluation and come up with a treatment plan. Let's see, someone asked if there's a distinction between having trauma and having PTSD. So absolutely, many kids will experience a trauma and not develop PTSD. PTSD is a disorder that develops in reaction to being exposed to a trauma. And again, not all kids or adults that experience a trauma will develop PTSD. There's a number of different factors that go into kind of contributing whether a kid is going to develop PTSD or not. But the two are totally separate. The relationship being that to develop PTSD, you typically do have to have some form of trauma. Somebody else again asked about, a kid wanting to stop therapist or wanting to stop counseling and try it their own way. After only 2 sessions, I would say most therapy takes about 20 sessions at minimum in optimal settings. So 2 sessions would probably not be enough. That's barely enough to kind of get to know a kid. Not really to have much significant impact. So I would encourage you to kind of stick with it. And then somebody else asked if I offer therapy sessions, and unfortunately I do not. As a training director, I do a lot of teaching, and I do supervise residents, fellow psychology interns and social work interns at a training clinic, and they do the bulk of the patient care. I think that's everything from the Q&A.
Yeah, I think that's about it.
Guys? Okay.
Yeah. All right. So with the Q&A question, oh, I think you have one more. Someone just put one. Yep.
All right, let me open it back.
I can read it for you. So the question is the COVID-19 pandemic considered a traumatic event for children?
So the pandemic in and of itself probably wouldn't be considered a trauma, but it would really depend on how it impacted a particular child. So typically when we're talking about a traumatic event for a kid, that means either their life or functioning being severely threatened, or them witnessing the threat to a loved one. So certainly if they had a parent who developed COVID and had to be hospitalized and almost died, that would be traumatic. But just kind of sitting back passively witnessing the pandemic, maybe not so much. Now, certainly there are other types of disorders. One of the most common disorders we didn't touch on because it's a little bit more global is what we call adjustment disorder. And that's what we tend to see a lot of right now with the pandemic, which is whenever we can see this when kids experience a divorce or a family disruption or a loss of a parent or a big move, the triggers for an adjustment disorder are kind of endless. But certainly the pandemic is a huge one, something that changes the way a child lives their life and they have difficulty coping with that. That's what we would call an adjustment disorder. And that can present with symptoms of depression, symptoms of anxiety, or behavioral symptoms.
So we do still have some time. So we have 2 more questions. The first one is being gay caused by trauma?
No.
All right. Straightforward. I like it. The next one is for driving panic, for going back on highway, should bring the kid to see. Okay, this is yeah.
I would probably start with a therapist because that seems like a very specific type of phobia. And I think you would want to encourage the kid to try to develop strategies to overcome that phobia. Now, if therapy isn't helpful, then the therapist might recommend medication, but I think therapy would definitely be the first start. I'll tell you guys, for the parents that are listening and the kids that are listening, of all the kids that I see and evaluate, I recommend therapy for pretty much almost every single one of them. I don't always recommend medications. That really depends on the severity and a bunch of other factors. But therapy is usually the best place to start.
All right, thank you so much. And I don't think there are any questions left. So thank you again so much tonight for coming to our event, Dr. Klisz-Hulbert. Thank you everyone who attended today in the audience. Don't forget to check out those 2 free documentaries and make sure you guys have a wonderful evening.
今天 Tom 去打了 COVID 疫苗，这是因为所有年满12岁的人都有资格接种 COVID-19 疫苗。于是 Tom 帮他姐姐找到疫苗接种的地点，他姐姐把链接发给了闺蜜，闺蜜提醒了工作伙伴，工作伙伴又告诉了他的会计师。好吧，你也知道是怎么回事了。今天这一切都是由 Tom 开始，明天就会是由你起头。是时候让家人和朋友都知道，疫苗几乎能100%预防因 COVID 而带来的住院和死亡风险。抗击疫情，我们做得到。